Hello, everyone, and welcome to the May issue of DermSurgery Digest. I'm Michael Renzi with Lexington Clinic Dermatology, co-host of the podcast. This month, we are continuing with our updated format, which will separate the surgical oncology and reconstruction portion of the Dermatologic Surgery Journal into two 30-minute episodes. This episode, which we are calling Rapid Pearls, will briefly cover the clinical application of data from each article not covered in our Spotlight episode. Our goal with this format change is to make the content more digestible with a focus on clinical application and enhancing patient care. Our feature editors for May are Yesul Kim with Fairfield Dermatology, who will be providing the article summaries, and Divya Srivastava, professor and the director of Mohs Surgery and Dermatologic Oncology at UT Southwestern Medical Center, who will be providing the expert commentary. Thank you for listening. We hope you enjoy this new format, and as always, have a happy surgery day.
Welcome to the Rapid Pearls section for May's edition of the Dermatologic Surgery Journal. My name is Yesul Kim, and I'm a Mohs surgeon practicing in Connecticut. This month's featured expert is Dr. Divya Srivastava, who is a professor and director of Mohs Surgery and Dermatologic Oncology at UT Southwestern. Thank you again for so much for joining us today.
Thank you so much, Dr. Kim and Dr. Lawrence, for having me on the podcast today.
This episode will feature quick article summaries and Dr. Srivastava's rapid pearls from the articles published in May's issue of Dermatologic Surgery. Our first article is Survival Outcomes in Cutaneous Angiosarcoma, a meta-analysis by first author Neri Patel and senior author Jenilyn Smith. This study was a meta-analysis of outcomes across treatment modalities and clinical stages in 159 patients with angiosarcoma. Authors found that angiosarcomas have a very high recurrence rate of 71.3%. And they also found that no treatment was independently associated with improved survival, recurrence, or metastasis, and tumor location of the scalp was the most consistent predictor of poor overall survival in medium to late stage angiosarcomas and older age and early stage angiosarcomas. So, Dr. Srivastava, do you perform surgery for angiosarcomas?
I have not performed surgery. I've not performed Mohs for angiosarcoma, partly because of potential non-contiguous margins. And again, there's no clear benefit to doing Mohs based on, the data that we've seen. I think people offer, and I think that's wonderful, but I think that we're not seeing that Mohs gives a survival advantage or, an improved recurrence rate. So I've not offered it. Typically, I recommend most of these patients who have advanced angiosarcomas are referred to like a tertiary care center, optimally with a sarcoma work group.
All right, the next article is Adverse Psychological Events Associated with Mohs Micrographic Surgery Rapid Review and Meta-Analysis by first author Karen Schmalling and senior author Arthur Bloom. This was a review and meta-analysis on psychological adverse events associated with Mohs in the perioperative period. Interestingly, psychological adverse events of Mohs is common, and patients report an average of 25.26 out of 100 reported some anxiety with significant heterogeneity, and no study's confidence interval included 0, indicating some distress was experienced by those in each study. Furthermore, authors reviewed Mohs consent forms by Google search, and they found that none of these 20 consent forms that they found mentioned anything about psychological risks. So I personally don't disclose any adverse psychological events in my informed consent process. Is this something that you disclose to your patients?
Yeah, I think that probably we're discussing it in an informal way because I think we're all managing our patients' expectations. They're coming in there and they'll say, hey, I'm nervous. And we say, I know it's always stressful having surgery in the face. And we're using our talk aesthesia to help them relax. And we're explaining to, we're managing their expectations about what's going to happen that day and their scar and their recovery timeline. So I think while it might not be something that's like formally listed, I think probably every Mohs surgeon is an expert in doing surgery while patients are awake and getting them through the process. So I think there's a lot of good studies also showing that patients have, high level of stress on the day of surgery, but then like a week later, they're like, wow, I had a lot more anxiety than I think I needed to. So I think that patients ultimately can do well, but I do think there's a subset of patients that have been shown to have higher stress levels. Sometimes it's women, patients with larger tumors. And I think there is a role for patients if they're having a lot of stress from this. there's a field of like oncopsychology you can send patients to. And I think I've had a couple of patients especially with vulvar cancers that we've employed those resources, and that's been helpful.
Mm. Do you ever use anxiolytics before Mohs, and what do you prefer?
Very, very rarely, probably less than a handful of times a year. And typically I'll send in Valium, 1 to 2 milligrams. But most patients, if they're calling concerned, we talk about the procedure over the phone and they feel like they're going to be more comfortable. And there's been some good studies also showing that if the patient takes NSAIDs the night before, their like perioperative pain is less, I think a lot of people have anxiety about the pain of the procedure.
Agree. All right. The next article is Topical Vitamin C in the Prevention and Treatment of Actinic Keratoses and Non-Melanoma Skin Cancers, a Systematic Scoping Review by first author Leah Johnston and senior author Susan Pullman. So vitamin C is a water-soluble vitamin that plays an important role in our skin. It also acts as an antioxidant to remove free radicals from the skin. So the authors performed a systematic review on the current evidence on topical vitamin C in the prevention and treatment of actinic keratoses and skin cancers, and only 4 studies met the inclusion criteria. They found that a highly concentrated topical formulation of vitamin C may have some benefits for low-risk non-melanoma skin cancers or actinic keratoses, but because only a small number of clinical studies have been conducted on this topic, it really limits us to generate any good clinical recommendations. What were your thoughts about this study?
Yeah, I think that this is a very, very limited study, very short follow-up. We all know that, once you've biopsied a non-melanoma skin cancer, oftentimes you have a scar even at your, Mohs surgery appointment. You just see scar in the area. It's possible that the squamous cell that was, in this case, could have even been a keratoacanthoma, and we know those can result with biopsy. So I think that the follow-up, it was very short term, and we know these non-melanoma skin cancers take several years to recur. So I think that, I think that this was just too limited to make me want to change my practice pattern.
I agree. The next article is Congenital Malalignment of the Great Toenail, Spontaneous Regression Rate and Limiting Factors for Surgical Outcome by first author Olivia Bathot and senior author Bertrand Brickert. According to the literature, an estimated 50% of reported cases of congenital malalignment of the great toenail resolve by the age of 10, thereby justifying a wait-and-see approach as an acceptable treatment option. But if no improvement is noticed, surgery can be performed. The study summarized some congenital malalignment of the great toenails and identified limiting factors for spontaneous evolution and surgery based on a severity score that the authors developed. They found that in their wait and see group, patients reported improvement or complete healing in 82.8% of cases. The authors described their details about their surgery, and they found that the surgery is very effective and provides excellent cosmetic outcomes no matter the age or severity. Any comments about this study?
I think that this is a condition that can be really challenging for patients to tolerate. So I think that if you have access to surgeons who are doing these nail procedures, I think it's a great thing to offer your patients.
Agree. All right. Next is a communication article called Squamous Cell Carcinoma Arising in a New Attack 2 by first author Kush Maheshwari and senior author Richard Wagner Jr. These authors presented a case report of a 70-year-old woman with a well-differentiated squamous cell carcinoma that was histologically not typical of a keratoacanthoma located within attack 2, which she received just 1 week prior to the appearance of the lesion. It's thought that the trauma from the ink injection induces inflammation and cellular damage, potentially contributing to genetic mutations in the skin cells, and the TAC2 pigment may trigger a persistent inflammatory response. Squamous cell carcinomas are most commonly observed in TAC2s containing red ink, but less described in black ink. And this case was also very unusual because the squamous cell carcinoma developed so shortly after the TAC2, and it was not histologically consistent with a keratoacanthoma type of squamous cell. Have you ever seen anything like this?
We definitely see a lot of skin cancers in the tattoo field, and sometimes it is relatively quickly after. And I think, and I always think, okay, this is like more of a keratoacanthoma type, and the pathologist is like, well, it looks more like a classic SCC, but I think sometimes there could just be some sampling error in there, but I've definitely seen it rapidly after tumors, but then also several years later, which I just think is, I practice in Texas where there's a lot of sun exposure, and oftentimes this is on, a forearm or, a neck, and you're just getting a lot of sun exposure in these areas. So it just might be two things that are unrelated. But I do think it's a good opportunity for us to educate tattoo artists to say, hey, let your patients know this is something they should be on the lookout for. Just like we've educated hairdressers about things to look for their patients. We all know we get a lot of our patients say, oh, my hairdresser told me to come see you. And so similarly, I think we can pair with a tattoo artist to say, hey, let your patients know that this is something that they have to have on their radar.
Yeah, that's a very good idea. The next article is Assessing the Risk, Infection After Mohs Surgery and Ear Wedge Excision Repair by first author Jay Patel and senior author Mark Brown. This communication gives background on that the reported infection rate for ear wedge excisions is at as high as 8.5% in the current 2008 advisory statement of prophylactic antibiotics in dermatologic surgery. However, this data was based on a single-center descriptive study of 35 cases, and since then, some studies report less than 5% infection risks in these locations. So the authors aim to characterize the post-operative infection rate of ear wedge excision repair during Mohs, and they found a low surgical site infection rate for ear wedge excision repairs of 2.6% during Mohs surgery in contrast to previous reports. So the authors do not recommend routine prophylactic antibiotics for patients undergoing Mohs and ear wedge excision repairs. Do you routinely give antibiotics for ear wedge or ear repairs at all?
Now, typically we don't routinely give antibiotics for most of our Mohs surgeries in our practice. If, we do some counseling to patients about what to look for. But I think, again, I agree with these authors that the infection rates are really, really low. And a lot of the times for people who do give routine antibiotics and patients are not getting infected, it's just because the infection rate's low. And I do think patients will come in with like chondritis. And if the thought is, oh, this is they'll go to urgent care and it's like, oh, you had surgery, it's red, must be infected. And of course, we see this with the lower legs too, where they show up in urgent care and they're like, oh, you told me it wasn't infected, but it was. And we know that this was just chondritis or stasis for the legs. So I think that there's probably was previously some misdiagnosis. So I think that this just highlights again the low infection rate and that we don't need to give everyone antibiotics.
Yeah, agree. Next article is Mohs surgery defect closure using blepharoplasty by first author Bert Greenberg and senior author Michael Borenstein. The upper eyelid skin is very thin, it's pliable, it's hairless, and closely resembles the skin of the face in color, texture, and thickness, so it makes it an ideal donor site for facial reconstruction. So the authors describe a 28-case study in which upper eyelid skin was obtained through cosmetic blepharoplasty and then used as a donor graft for reconstruction of Mohs defects in the paranasal, periocular, and upper cheek regions. The overall graft survival rate was 100%. It had some excellent cosmetic outcome with some examples of the patient's results published. Do you ever harvest a full thickness skin graft from the eyelid or perform blepharoplasties?
I have used the upper eyelid skin for a donor site. I think it's a great match for like lower eyelid, medial canthus, which are great sites for grafts. It's not my first go-to site, though. I think sometimes patients are concerned about the asymmetry. And yes, you could do the contralateral side, but you also have to think about managing resources. This isn't something that, you can bill to insurance. And at the same time, it's tough sometimes to tell a patient, hey, I'll do this for you for a fee at the same time. But I think it's completely acceptable to do that. To get value for the work that you're performing. But usually it's not my go-to site, but I have used it. And I do think it blends really nicely to the lower eyelid and the medial canthus. And I think the closure looks beautiful. I, recommend doing like 6-0 monocryl, and you don't really even need that many deeps, maybe 1 or 2. Some people don't put any deeps in, and fast cut on top. And I think these heal beautifully.
Agree. All right, so the next article is Comparative Analysis of UV Lamps for Identifying Biopsy Sites in Dermatologic Surgery by first author Bharath Balu and senior author Michael Renzi. So identifying biopsy sites can sometimes be a significant challenge in dermatologic surgery. Traditional Woods lamp, which emits broad spectrum UV light of 320 to 400 nanometers, can be used to identify prior biopsy sites. So the authors wanted to compare the use of UV black lights, which emits wavelengths of 365 nanometers or 385 to 395 nanometers versus a standard Woods lamp. All three UV light sources were effective, but it seems like the 385 to 395 UV black light stood out as the brightest and the most effective. So, do you ever use any Woods lamp to identify biopsy sites at all?
Typically I don't, but I do think it's a good resource, or using dermoscopy. And personally, for every single patient, I take an alcohol swab and I kind of irritate the skin. And I think that helps highlight it, highlights more erythema in the biopsy site. So that's typically my go-to. But I do think if you're having trouble, I think that Woods lamp is a good aid. And I learned that, yes, maybe my practice is going to get one of these 385 to 395 nanometer lights to have around to help in those tougher cases to identify the site. And I think, again, the mainstay is making sure you've got good photography and communicating with your staff to take good pictures of biopsies, and communicating with your referring physicians if there's an issue about identifying the site.
Yeah, and this segues well to the next article, which is a simple photograph, a safer surgery, preventing wrong site errors with smartphone documentation by first author Shinjini Das and senior author Adam Rotunda. In the author's practice, they encourage patients to actually photograph their biopsy site using a smartphone, ideally soon after biopsy, and ask the patient to bring their phone or printed copy of the image. This simple step, alongside other safeguards, adds a layer of redundancy and verification that helps reduce risk of wrong site surgery. Although clinical photography at the time of the biopsy remains the gold standard, a patient-taken smartphone photograph can be a useful supplemental photo that is low effort, which can be an additional way to prevent wrong site surgery. I think this is a great idea. Do you ever have your patients do this as well?
Yes, this is a big part of our practice, and my is really go about to identify the surgical site. So when we get a referral, if it's not a photograph that the reference office has sent in, or we don't have an internal practice biopsy, then we call the patient and say, hey, take a picture right now of your defect, and they can mail it to us either through our patient portal or a secure email address. And even though they can bring it with them the day of, just in case they forget their phone at home, just send it to us now also, so we can have the chart, and then we can also do a plan. There's a setting in, at least, I can put a mirror toggle on. And so sometimes I'm like, oh, they said right cheek, but there was a cheek. And then we realize it's because of this mirror toggle. So you can, on the front facing camera, if you can practice with yourself, stick a Post-it on your cheek and say, okay, did it show up on the right side? If you toggle on, it shows up on the correct side. If you have the toggle off, it's going to show up on the contralateral side. So it's the only place you need to be careful is with the patient selfie, is that, like, sometimes you've just got to make sure you're double checking that you have the right lateral eye.
That sounds good. Yes, that's a good idea. All right, the next article is nail cutter as a tool to remove necrotic bone and stimulate granulation tissue on exposed scalp bone by first author Helen Chen and senior author Ziv Schwartz. The authors describe an alternative technique of using nail cutters to snip off pieces of necrotic bone, resulting in pinpoint bleeding rather than traditional methods of bone burring using scalpels or hand drills, motorized drills, or chisels. The drawback is that there's a theoretical risk of compressive force on the underlying bone, which can lead to displacement or injury to adjacent structures. The advantage is that the nail cutter allows for more precise control over depth of bone removal and minimizes the risk of excessive drilling, also produces less tissue particle spray. How do you like to deal with your necrotic bones?
And so I'll say the main time I'm kind of curetting bone is really to stimulate debrided necrotic bone. Usually I'm working probably like in a multidisciplinary team with either ENT or plastics, but it's really, if I'm curetting bone, it's because we've got exposed bone after Mohs and I want to get some granulation tissue, and I'll use, disposable curette to do that. I think that's the one time I love using a disposable curette because it's so sharp, and I'll kind of create little burr holes using that. And otherwise, we work a lot with our ENT and plastic surgeons to do the drilling in the OR because I think that's where it's most comfortable for the patient. I've never used a nail cutter for scalp bone and removing necrotic bone, but I have used it for like nail, if I run into positive nail, like in a squamous sarcoma, I use a nail cutter to remove that superficial bone and send it for pathology.
All right. The next article is The Bipedicled Flap for Anterior Ingrown Toenail by first author Henry Seng and senior author Khaled Turki. Authors used a bipedicle flap created from residual hyponychium, which allows for complete clearance of the nail bed, and the flap allows for a stable, well-vascularized foundation that prevents the nail from re-embedding into hypertrophic tissue. It also ensures complete clearance of the nail bed and reduces recurrent rates. Any comments about this study, about the bipedicle flap?
Super interesting. And sometimes we'll just do like a lateral nail avulsion so that we can still maintain most of their nail in place. I think this one was for the anterior toenail. Yeah, I think it's an interesting technique, but probably I would perform for that a total avulsion and just fresh and granular.
Thank you so much, Dr. Divya Srivastava, for just being here with us today and just giving us your clinical insight and all of your knowledge today.
Thank you so much. I really enjoyed being here, and thanks for your hard work on this. Thank you.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.